Welcome to Board Pearls. This is episode 3 of 6 of the GI and pregnancy chapter in the special populations and acute or supportive care module. In this episode, we cover the pregnancy-specific liver diseases, intrahepatic cholestasis of pregnancy with elevated bile acids and ursodeoxycholic acid, the preeclampsia, HELLP, and AFLP spectrum, where delivery is the definitive treatment, and hepatic rupture as the catastrophic complication. Liver disease in pregnancy splits cleanly into two halves, and the split is the way to think about every stem you will see. On one side are the pregnancy-specific syndromes. They exist only because pregnancy is occurring. They resolve with delivery, and delivery is the treatment. On the other side is incidental hepatic disease, viral hepatitis with drugs that are safe through pregnancy, and pre-existing liver disease where pregnancy changes the management. This episode covers the pregnancy-specific syndromes because the recognition pattern and the trigger for delivery is what the boards test hardest. Begin with intrahepatic cholestasis of pregnancy, the most common pregnancy-specific liver disease. U.S. prevalence is roughly 1 to 2%. The Araucanian Indian population in Chile runs as high as 27%, which is a clue that the susceptibility is genetic. The susceptibility genes encode the canalicular bile acid transporters. ABCB11 encodes BSEP, the bile salt export pump. ABCB4 encodes MDR3, the phospholipid transporter. ATP8B1 encodes FIC1, an aminophospholipid translocase. Variants in these genes reduce the capacity of those transporters to keep up with the bile acid load that estrogen and progesterone impose in late pregnancy. The hormonal milieu pushes a system that is already running near its limit past its limit, and bile acids accumulate. Severe ICP, recurrent ICP, or early onset ICP should prompt genetic testing, because some of these patients turn out to carry benign recurrent intrahepatic cholestasis, or PFIC variants that change long-term hepatobiliary care. There is one other susceptibility worth knowing. Hepatitis C raises ICP risk about 20-fold, because HCV further impairs bile acid transporter function. So HCV serology belongs in the ICP workup. The presentation is in the second or third trimester, typically 25 to 32 weeks, with pruritus that is worse at night and predominantly involves the palms and soles. The pruritus is often the only symptom. It can precede the laboratory abnormalities, which means if a patient has classic palmoplantar nocturnal itch and normal initial labs, the right move is to recheck. Jaundice happens in only 10 to 25% of cases, and it always follows the pruritus. The diagnostic threshold is total bile acids above 10 micromole per liter. Severe disease is bile acids at or above 100. The biochemical signature that discriminates ICP from obstructive cholestasis is GGT. Alkaline phosphatase is up. 5. Nucleotidase is up. AST and ALT can rise, sometimes briskly, but they rarely cross 1,000. GGT, however, is characteristically normal. The reason is mechanistic. The BSEP, MDR3, or FIC1 defect impairs canalicular bile acid handling without producing the ductal injury that drives GGT release. Obstructive cholestasis injures the ducts and lifts GGT. ICP impairs the transporter and leaves GGT alone. That is the discriminator. A stem that gives you bile acids in the 80s, AST in the hundreds, ALP up, and a normal GGT is ICP. The same labs with a high GGT is biliary obstruction, and the next step is ultrasound and MRCP, not UDCA. Right upper quadrant ultrasound to exclude obstructive disease still belongs in the ICP workup before you finalize the diagnosis. The treatment is ursodeoxycholic acid, 10 to 15 milligrams per kilogram per day, titrated to symptoms. Roughly 500 to 2,000 milligrams a day in practice. The mechanism is direct. UDCA is hydrophilic. It competes with hydrophobic toxic bile acids in the bile pool, displaces them, and improves canalicular transport. It also crosses the placenta, where it protects fetal cardiomyocytes from bile acid-induced arrhythmia. About 3/4 of patients respond with reduced bile acids and reduced pruritus. There is an important caveat. A large randomized trial did not show fetal outcome improvement with UDCA versus placebo, which raised real questions about routine use. UDCA remains recommended anyway because it produces clear maternal symptomatic and biochemical improvement, and subsequent meta-analyses suggest fetal benefit at the higher bile acid levels where absolute risk is highest. The posture is continued use, with that trial informing nuance rather than abandonment of therapy. Vitamin K is given around delivery because cholestasis impairs fat-soluble vitamin absorption and raises peripartum bleeding risk. Cholestyramine is the alternative for patients who cannot tolerate UDCA, but it is poorly tolerated itself and worsens fat-soluble vitamin malabsorption. So UDCA is the answer, and cholestyramine is the second line. Now the part of ICP that organizes everything else. Why is the disease taken seriously? Fetal mortality. Bile acids cross the placenta and bind fetal cardiomyocyte, muscarinic, and bile acid receptors, producing arrhythmia, while hydrophobic toxic bile acids deposit in fetal tissues. A large individual patient data meta-analysis stratified fetal risk into 3 tiers based on maternal total bile acid level. Below 40, fetal mortality is close to baseline. 40 to 99, it is modestly elevated. At or above 100, the curve inflects sharply. Stillbirth risk in the severe group is approximately 3.4% versus 0.13% baseline. That stillbirth inflection is what drives delivery timing. The principle is that you induce when the fetal mortality risk of staying in utero exceeds the fetal lung maturity risk of coming out. Below 40, mortality is at baseline, so you deliver at 39 weeks as you would in any uncomplicated pregnancy. 40 to 99, you deliver between 36 and 39 weeks, individualized by symptom control and obstetric factors. At or above 100, you deliver at 36 to 37 weeks, because the steep stillbirth risk outweighs the modest gain in fetal lung maturity from waiting another 2 weeks. The whole stratification answers one question: where on the curve does the patient sit, and where is the curve inflecting? ICP resolves within 1 to 2 weeks postpartum. Pruritus goes away. Bile acids normalize. But recurrence in the next pregnancy is high, 60 to 90%, and ICP also recurs with combined hormonal contraceptive use because exogenous estrogen does the same thing as endogenous estrogen to the transporters. So combined hormonal contraception is generally avoided in a patient with prior ICP. Progestin-only options or non-hormonal options are preferred. Long-term, these women have elevated risk of HCV, non-alcoholic cirrhosis, gallstones, and non-alcoholic pancreatitis. Long-term follow-up matters. That is ICP. Now to the third trimester emergencies, which share the feature that delivery is the only definitive treatment, and which test as a recognition problem in which 2 distinct mechanisms produce overlapping clinical presentations. Preeclampsia is hypertension at or above 140/90 with proteinuria or end organ dysfunction after 20 weeks of gestation. It affects 3 to 10% of pregnancies. Severe preeclampsia is BP at or above 160/110 or any end organ dysfunction. Oliguria, pulmonary edema, neurologic symptoms, persistent epigastric or right upper quadrant pain, hepatocellular injury, thrombocytopenia, or fetal growth restriction. Liver involvement happens in 10 to 20% of preeclamptic pregnancies. HELLP is the severe end of the same vascular pathology. The acronym names the lab triad: hemolysis with LDH at or above 600, elevated liver enzymes with AST at or above 70, low platelets at or below 100,000. Those are the Tennessee criteria. The Tennessee classification then stratifies severity by platelet count. Class 1 is platelets below 50,000 and carries the highest maternal mortality. Class 2 is 50 to 100,000. Class 3 is 100 to 150,000, with the most preserved hemostasis. The classes correlate directly with bleeding risk at delivery and with how aggressively you transfuse platelets. HELLP affects 0.1 to 0.6% of pregnancies. It develops before delivery in 70% of cases and after delivery in 30% within 2 weeks postpartum. And 20% of HELLP cases occur without hypertension, which is the part that catches the diagnosis off guard. The shared mechanism of preeclampsia and HELLP is vascular. Placental endothelial dysfunction releases anti-angiogenic factors, SFLT1 and soluble endoglin, that produce maternal endothelial injury, vasoconstriction, and microvascular fibrin deposition. In the liver, Fibrin thrombi in hepatic sinusoids produce sinusoidal obstruction and periportal hepatocyte ischemic necrosis with periportal hemorrhage on histology. The hemolysis in HELLP is microangiopathic. Red cells fragment physically against fibrin strands in injured small vessels, which is why you see schistocytes, low haptoglobin, and elevated LDH. Liver enzymes can reach the thousands. Bilirubin usually stays below 5 and is mostly unconjugated from the hemolysis. Maternal mortality in HELLP is 1 to 3.5%. Perinatal mortality runs 56 to 367 per thousand live births. The disease can worsen in the first 48 hours after delivery before it improves, which is a counterintuitive piece of the post-delivery course worth holding on to. Treatment of preeclampsia in HELLP is delivery as the definitive intervention. The reason is that the placental endothelial dysfunction does not resolve until the placenta is gone. You can manage the consequences with ICU monitoring, blood pressure control, magnesium sulfate for seizure prophylaxis, and antenatal corticosteroids for fetal lung maturity if delivery is less than 32 weeks. Platelet transfusion to above 40,000 at delivery or for procedures is part of the supportive package, but none of those treat the disease. Only placental removal does. Recurrence in subsequent pregnancies is approximately 7%. AFLP is the other third trimester emergency, rarer, with a different mechanism and the high-yield board distinction. Roughly 1 in 6,600 to 20,000 pregnancies. Mean presentation at 36 weeks. Risk factors include multigravida status, twin pregnancies, coexisting liver diseases of pregnancy, and male fetal sex. The presentation is rapid onset jaundice, coagulopathy, hypoglycemia, and lactic acidosis. The mechanism is testable directly, and it is what separates AFLP from HELLP. AFLP is driven by fetal long-chain 3-hydroxyacyl-CoA dehydrogenase deficiency, LCHAD. The mother is heterozygous for the LCHAD mutation. The fetus is homozygous. Defective fetal beta-oxidation of long-chain fatty acids spills unmetabolized long-chain fatty acids into the maternal circulation, where the maternal hepatic mitochondrial fatty acid oxidation pathway becomes overwhelmed. The result is microvesicular steatosis, predominantly in zone 3 of the liver, with non-membrane-bound triglyceride and free fatty acid droplets, and hepatic architecture is otherwise preserved with subtle or absent inflammation. The mitochondrial dysfunction explains everything you see clinically. Impaired gluconeogenesis produces hypoglycemia. Impaired hepatic synthesis produces coagulopathy. Ammonia accumulates and produces encephalopathy. Impaired pyruvate metabolism produces lactic acidosis. The phenotype is a mitochondrial fatty acid oxidation crisis in the maternal liver, triggered by a fetal genetic defect. The Swansea criteria establish the diagnosis when 6 or more features are present in the absence of another explanation: vomiting, abdominal pain, polydipsia or polyuria, elevated transaminases, elevated bilirubin, renal impairment, encephalopathy, hypoglycemia, coagulopathy, ascites or bright liver on ultrasound, microvesicular steatosis on biopsy, leukocytosis, elevated urate. The positive predictive value is about 85%. The negative predictive value approaches 100%. That is why biopsy is rarely necessary. Distinguishing AFLP from HELLP is the high-yield board distinction, and it follows directly from the mechanism. AFLP-specific features are hypoglycemia, encephalopathy, coagulopathy, polydipsia or polyuria, microvesicular steatosis, elevated urate, and marked leukocytosis often above 15,000. The AST to ALT ratio in AFLP runs above 1. HELLP-specific features are microangiopathic hemolysis with schistocytes, markedly elevated LDH, and deep thrombocytopenia. Both can present with vomiting, right upper quadrant pain, transaminase elevation, bilirubin elevation, and renal impairment, which is why the overlap traps the diagnosis. About half of AFLP cases also have features of preeclampsia, which is the other reason the discrimination matters. The way to keep the distinction straight is to remember what each disease is, mechanistically. HELLP is a microvascular fibrin and shear problem. So you look for evidence of shear, schistocytes, hemolysis markers, deep thrombocytopenia from consumption. AFLP is a mitochondrial fatty acid oxidation problem. So you look for evidence of mitochondrial dysfunction, hypoglycemia, hyperammonemic encephalopathy, coagulopathy from synthetic failure, lactic acidosis. Management is delivery as the only definitive treatment, ICU supportive care, imaging to exclude hepatic hemorrhage or rupture, and liver transplantation for worsening liver failure, which requires transfer to a transplant center. Both mother and infant undergo genetic testing for LCHAD deficiency. Infants with confirmed deficiency develop non-ketotic hypoglycemic coma with stress or fasting, which is reversible with adequate feeding once recognized. Historical maternal mortality without prompt delivery was 70 to 80%. Modern mortality with timely delivery and supportive care is 10 to 33%. That order of magnitude reduction with delivery is the empirical foundation for treating AFLP recognition as a delivery emergency rather than a medical disease. Fetal and perinatal mortality remains substantial, on the order of 15 to 25% in contemporary series, and higher, up to roughly 60%, in the subset with LCHAD deficient fetuses. Then there is the catastrophic complication that sits inside this spectrum, hepatic infarction with subcapsular hematoma or capsular rupture. It is rare, occurring in roughly 1 to 2% of HELLP and severe preeclampsia pregnancies. Hepatic hematoma is reported in a larger minority of HELLP patients, but progression to capsular rupture stays in the 1 to 2% range. AFLP can also produce it, less commonly. The presentation is sudden severe abdominal pain, often radiating to the right shoulder or scapula from diaphragmatic irritation. That referred pain is the pregnancy analog of care sign. Transaminases often crash through 3,000 to 6,000 units per liter. Spiking fevers. Anemia from blood loss into the subcapsular space. CT or MRI shows predominantly right lobe involvement. The decision tree depends on hemodynamics. A hemodynamically unstable patient with active bleeding gets aggressive resuscitation with blood products and either surgical intervention or hepatic artery embolization by interventional radiology. Maternal mortality in that scenario runs 56 to 75%. Fetal mortality runs 62 to 77%. A hemodynamically stable patient with a contained subcapsular hematoma is managed conservatively with correction of coagulopathy and serial imaging. It helps to keep a differential by trimester as a recognition guide. First trimester through 20 weeks, hyperemesis gravidarum. Second to third trimester, intrahepatic cholestasis of pregnancy. Third trimester after 20 weeks, preeclampsia. Third trimester after 22 weeks, HELLP. Third trimester after 28 weeks, AFLP. Jaundice in the third trimester is concerning regardless of position within that window, and it prompts parallel evaluation for ICP, preeclampsia or HELLP, AFLP, and viral hepatitis. Pull the pregnancy-specific half together. These syndromes exist only because pregnancy is occurring, and delivery is the definitive treatment for all but ICP. Intrahepatic cholestasis sits on a stillbirth risk curve that inflects sharply at total bile acids of 100, and ursodeoxycholic acid plus bile acid stratified delivery timing is the answer, with the normal GGT the discriminator from obstructive cholestasis. The preeclampsia, HELLP, and AFLP spectrum runs on two mechanisms, vascular fibrin and shear for preeclampsia and HELLP, and fetal LCHAD-driven mitochondrial overwhelm for AFLP, and you tell them apart by looking for shear versus mitochondrial failure. And hepatic capsular rupture is the catastrophic complication that hemodynamic status triages. The next episode takes the incidental half of the chapter, the hepatic disease that is not caused by pregnancy, but is reshaped by it, viral hepatitis with its virus-specific transmission and antiviral decisions, and pre-existing liver disease, where the rule is continue what works and swap out the teratogens. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 3 of 6 of chapter 35, and I'll see you in the next one.